Good morning, everybody. I think the toughest part of this talk is going to be staying inside this box because I'm kind of a walker talker. And so if I start walking in place, you know what I'm doing. So the topic for today's talk is the on-call crisis and potential solutions for the on-call crisis. And the first thing you might be asking yourself is, why do I care, right? It's the hospital deal, it's the specialist deal, and I kind of want to suggest that, that it's our deal. It's our deal too, because as much as we'd like and as much as we think we practice independently, we don't. We're all kind of like acrobats, on a tightrope. We're all twirling plates. There's a CO next to me, there's a nurse next to me, there's a specialist next to me, and if any of them fail, we're going to fail. Okay, so I'm going to suggest that we need to help the people out around us, especially the ones that are closest to us. So the goals for the talk: how do we get into this crisis? What is sort of the horizon for the future? What are the legal regulations that sort of affect on-call coverage? Because that has a great bearing on our potential solutions. And all the solutions kind of funnel down to the same road, which is you have to pay fair market value for compensation. And so we'll talk a lot about fair market value, what that mean, and how can you do it at your shop. And in the end, we'll talk a little bit about some potential solutions. They may or may not work for your shop, but to just be open-minded and put some ideas out there. And finally, the bottom line is tonight is when you go home, you're not going to solve their entire on-call problems at your hospital, but you will need to think about your hospital's vulnerabilities, particularly in the area of compliance. So on-call past. How come on-call crisis now? There's been on-call doctors like forever. I was a son of an anesthesiologist, and I knew what on-call meant before I could spell my own name. I knew what first call meant, second call meant, third call meant, trauma call, L&D call. So why now? Well, in the past, there was an incentive for new physicians to take call. That's how they built their practices. They took unassigned patients from the emergency department, hopefully paying ones, and then you kind of took the whole mix, and then you built your practice around it. Also in the past, the doctor would move into town, hang a shingle, and be there for 20, 30 years, right? So he really felt a part of the community. Usually lived in the same place where you worked, and your church was there, you shopped there, your kids were in Little League there, and so you really felt this obligation to the community. And third, it was kind of the stick for the hospital side to say, okay, if you don't take on call, you don't get hospital privileges, so you can't admit your patients here, and that's just the way it is. So that lasted for a really long time, right? So on-call generally wasn't an issue because physicians would staff the hospitals voluntarily without pay because they thought it was the right thing to do. It was a kind of a win-win situation. So how does that landscape change? Well, now physicians really don't need hospital privileges, so that stick is kind of taken away, especially if you're a surgical subspecialist. There's ambulatory care centers that you don't have to go to the hospital for, and a lot of doctors right now are kind of dividing in between the inpatient and outpatient world, right? So that there's that mega trend where a lot of the outpatient docs go, why do I need hospital privileges? Because I'm never there. So greater competition for the existing physicians, felt like I can, I'm like this neurosurgeon, I bring out, millions of dollars to your hospital, I don't want to take on call, what are you going to do about it? I will go to another hospital, or you give me it without a call. Much less feeling of obligation to the community. So doctors move, patients move, and so the whole idea of this long-term monogamous relationship is very different than what you got nowadays, where you just kind of you play the field, and they're one-night stands. You go from place to place, and it really don't feel an obligation to the community or the hospital. But probably the most important thing is that the doctors of the new generation, and this is a whole lecture on itself, what does the new doctor look like versus the older doctor? And I'm not going to name, ages or cutoffs. I don't want to offend anybody. But they say that, and this is a quote that Sherry loves, is that there's 1.7 new docs to replace an older doc because the new docs care about lifestyle. They don't want to work forever. They don't want to work all weekends, and it's more important than money. So this is why hospitals are losing specialty coverage. And I'm not going to go over this slide just in the sake of time, but they're losing specialty coverage because of pay, but also because of lifestyle issues. So the advent of the stipend, right? So ages ago, there was no stipend. And then all of a sudden in the 90s and the early 2000s, you started to see hospitals pay for essential services, to the point now that about 2/3 of hospitals pay a stipend for the call panel. In California, where we've been doing a project with a hospital, it's even worse. You know, in 2003, about 63% were paying stipends, but nowadays it's 80, 90%. So, you know, a hospital can't get anybody to take call unless they give them a stipend. And these stipends are rising, and they rise from different kind of segments of the market, but in general they're rising. And so this is sort of the crisis, because hospitals can't afford to keep escalating their cost of stipends. The physicians have sort of been in the driver's seat, and they've been demanding more and more, and so now it's kind of come to a head. So some legal considerations, and I'm not going to go into this a lot because I know there's a whole talk on this, but it's hard to do this talk without mentioning a couple. First, EMTALA, which I'm sure you're all aware. That's why people can come to the emergency department and get a medical screening exam. But the part of EMTALA that really kind of relates to on-call is the issue that the hospital is responsible for staffing on-call specialists. Not just the field, but by name. You know, Dr. Smith is on for anesthesia tonight, you know. And back when EMTALA was written, it was that the hospital is going to best meet the needs of the patient. And as time has gone on and it's been harder and harder to staff on call panels, they started to soften the language to where now it's in accordance with the resources available to the hospital. Leaves a whole lot more leeway, right? So in the past, there would be one doc to one hospital on call. In 2003, when the final rule came out, it was okay, one doc can cover 3 hospitals, you know, because we realized there ain't a neurosurgeon at every hospital. In 2009, they started coming up with the ideas of shared call panels, regional call, on-call panels for the community, which is a real shift in the thinking. Now, Stark laws, which I know you know a lot about, generally about self-referrals, but the real part of the Stark laws that applies to on-call is that if you're going to pay physicians, it's got to be at fair market value, okay? If it's not at fair market value, you could get prosecuted, okay? You could get investigated. Now, the anti-kickback statutes even applies more to the on-call situation, and it's a double-edged sword. You know, hospitals can violate it, physicians can violate it. So hospitals cannot bribe physicians for taking their business to their hospital. So it's not like, I'm going to pay you $5,000 a night per call, Mr. Ortho Doctor, because I want all of your elective cases. Because the OIG views this as unreasonable. Similarly, the physicians cannot say, hey, if you don't give me $5,000, I'm going to take my business to the ambulatory surgical center across the street. Okay? So it kind of goes both ways. Federal and state tax codes are important, mainly for tax-exempt organizations, because they have to have fair market value. Again, the common road back to fair market value. And then, you know, this whole law has been kind of murky. Like, how do you interpret EMTALA? How do you interpret the anti-kickback statute? And so there's a number of opinions that have come out by the OIG, and there's 3 that you should know about, which I'm not going to go into detail because of time, but this kind of lends an interpretation to what is fair market value and how can you pay physicians. And finally, medical staff bylaws is a real important thing. You want to get a copy of that. It's you know, we didn't become a lawyer for a reason, because they're thick and it's mundane. But you want to look through what applies to on-call as far as who gets to take on-call, how much are they going to get paid for, and when do they have to respond, and what are their duties. So the 2007 OIG essentially said that, you know, you can pay docs, but you got to pay them at fair market value. 2009 OIG advisory opinion says that, like in the days past, where you eat where you kill, like fee for service, where the doc says, okay, you don't have to pay me for being on call, but I'll come to the emergency department or I'll admit the patient, but I'm going to bill them, you know, because that seems fair. That's how I make my money. And the OIG says you can't do stipend plus keep the earnings. You can't get a great stipend or some other compensation method and keep the earnings. And we'll talk about this more. And the 2012 OIG opinion, which just came out, said, it's kind of funny because they said all physicians on the staff must be offered the opportunity to be on call, like it's a real gift. They don't want these backroom deals. They want, I did this with you, I did that with you, our contract is on this, napkin, and it'll apply for the next 6 months, but only when the football game's on. They have to be kind of like really objective, concrete, written agreements. So why does the government care? I mean, you're kind of thinking, okay, so the hospital wins, the doc wins, they're getting paid lots, the hospital gets the business. Why does the government care? It's because essentially they're writing the checks, indirectly. So it's all about cost, which is kind of, I guess, one of the themes of this conference. And the government doesn't want to be supporting the orthopod's ski home in Aspen based on the indirect fees they're paying for on-call. So before you start, you kind of need an assessment of your shop, and this is where it kind of take-home point, because a lot of hospitals are just unprepared for that. And my own group is starting just to get a handle on this. I work in Denver. Is kind of doing kind of a needs assessment, like, do we need on-call? How many unassigned patients are there? How many times do you need to come to the hospital? When you come to the hospital, how likely it is that you're going to need to do surgery? What's the payer mix, et cetera, et cetera. So the whole idea of commercial reasonableness came up, which is before you pay docs something for compensation for being on call, there has to be a need, okay? So this whole idea of commercial reasonableness. Let me give you an example. So I live in Denver, south of Denver, which I swear we have the highest number of orthopods per capita in the world, right? So like everybody's an orthopod. So like on the call panel, we just don't have ortho on call. We have spine on call, we have joints on call, we have trauma on call, we have hand on call, we have people on call for the right hand, people on call for the left hand. I mean, you can't go anywhere without tripping over an orthopedist, right? So why would the government say, okay, there's this huge, glut of orthopedists in the Denver area. Why do we have to pay on call? They're gonna take call. It's beneficial for them. They get paying patients. They're gonna do elective surgeries. So why pay? So different approaches to compensation. And I'll just put some out there. If I had a lot more time, I could go over the pros and cons of these to great detail. But the most popular one out there is stipends, meaning that you pay a set amount of money for a set amount of time. It's usually per day, per 24-hour day. So yeah, your hospital might switch at 6 o'clock in the morning, 7 o'clock at morning, whatever. But that's usually the predominant way. Now, fee-for-service is kind of the old way, where it's, again, you get nothing for being on call, except you kind of get patients, right? And you can bill those patients. Activation fee is where you get paid nothing if you don't get called, but if once you get called, it triggers, a payment. So this is good in some ways because, as an ER doc, you're calling somebody at 3 o'clock in the morning, instead of them saying, darn, I'm getting called, I almost had a no-call thing and I got $2,000. But in this way, they go, cha-ching, great, I love it when the phone rings. So there's the advantage. We're kind of going to the era of the RVU, where you're starting to pay a certain amount for intensity of services. And this is kind of fair, so if you get called, you get paid. If you do something really hard, you get paid. And if nothing happens, you don't get paid. But there's disadvantages to that. And then the big trend is employment. And this is kind of the profile of the new doc. The new doc nowadays likes to be employed. They don't want to hang their own shingle. And this works for the hospital because it takes care of the on-call issue, right? And it works for the doc too. So these are kind of pluses and minuses, pros and cons of these various methods. So stipends, easy to administer. I cut a check every day for everybody who's on the calendar. It's hard because the reason why it's not working is because the escalating costs, and what is fair market value for the work I do. Fee for service, it's fair. You come in, you see the patient, you bill them. And it counts for a workload. If you have a lot of work, you have less work. You get paid more, you get paid less, depending on how bad of a night you had or good of a night you had. The downsides, especially in areas where it's a poor payer mix, this really stinks, because you work the whole night and get paid nothing. Activation fee, easy to administer, and it's great for relationships, with the on-call provider because they like being called by the emergency department. The downside is it creates demand. The emergency department is not paying the bills, the hospital is paying the bills, so we tend to call unnecessarily. And then with all these things here, there's specialty rivalry, right? So, it's usually backroom deals, so the orthopod doesn't know what the neurosurgeon doesn't know what the hospitalist doesn't know what the pediatrician is making, because if they knew, somebody might be angry. And they usually find out in the doctor's dining room, so people are angry. So RVU is one of the things that's a trend in compensation. And again, you're getting paid by the intensity of services. Now, the real downside with RVU is really, really hard to keep track of, right? So, kind of medical staff administrators will say to us, so I got a bill from so-and-so on-call doctor was written, on his napkin, or he texted me something, or, it's so hard to keep track of. Employed model we talk about is really the trend to go. And a lot of patients, a lot of hospitals now are kind of going to a hybrid model. They're going stipend, smaller stipend, but an activation fee. So if you don't get paid at all, you get paid a little bit for carrying the beeper, but if you get called in, you get a bonus, which is kind of nice, right? The problem with hybrid models is the OIG does not like it when the hospital gives you a subsidy, especially a stipend, like a full stipend, and the doctor keeps the billings. It's like double dipping. It's like getting paid twice. The OIG really does not like this. The thing, though, is most of the country is doing it, right? So 2011 survey is that 72% of all on-call docs retain their fees. So, one thing, not to cause a huge chaos in the doctor's dining room, but you kind of want to start figuring out, if you're on medical staff sort of leadership, figuring out where is your hospital on this, because this is a real vulnerable area. So it all comes down to fair market value. So fair market value is the price that you would pay for something at arm's length distance. So if you had no dog in the fight, how much would you pay for a certain good, right? So for example, we drive old cars, okay? So I have a 14-year-old car, and I'm waiting to give that to my son, right? He's only 8 now, so it's going to be really old when he can drive, right? But Wesley, it's waiting for you, okay? So I'm probably not going to sell it to him for $1,000 or $500. He's my kid. I'll probably sell it to him, turn over the title for $5 or something, right? That is not fair market value, right? And so same thing with hospitals and physicians. It's like, well, if I didn't hire you and I went to locum tenens or put a public announcement out there for on-call services, what can I get that service at what price? So that's fair market value. So how do you determine fair market value? There's 2 general ways, okay? The one on the right is kind of the right way to do it, which is the RVU method, saying, it all depends on how much you work, because somebody's on-call is very different from somebody else's on-call experience. So if you're coming in and you're doing procedures, et cetera, you should be paid more, right? The problem is most hospitals, most providers don't have that data. They just don't. They don't keep track of who they see, who they talk to, and the work they do. So people kind of resort to the left-hand side, which is, let's take some surveys, let's see what's kind of out there, and we'll benchmark it, right? We're all about benchmarking here. So, and we'll pay you at the median, or 75th percentile or 25th percentile. By the way, it's a problem if you pay them at the 75th percentile, because the OIG doesn't want you paying anybody above the 50th percentile. So you need tons and tons of data, okay? To do the right way for the RVU method. And let me make this analogy. It's kind of like, you're going for a meal, right? And so last night, you could have gone to a restaurant and paid for every dish, every appetizer, every main course, dessert, drinks, etc. I won't ask you how many drinks you had last night. But you could pay for it a la carte, right? And that's kind of fair because, whatever you eat, whatever you pay, there's a price list on there. And then there's the buffet, right? So you pay one price, or the price fix, where you pay one price and you get the whole kit and caboodle, right? So this is the RVU method is sort of the a la carte way, and the compensation benchmarking way is kind of the buffet, the price fix way. So at our shop, we're still trying to get some of this data, right? So we use the T system, and we've made multiple iterations of our on-call sort of services that we require. So we ask them, who are we calling? Are they an established patient or are they an unassigned patient? Because it's all about the unassigned patient. So on-call docs should not be getting compensation if it's somebody in their practice calling them, right? Because if even they weren't in the hospital, they're getting that call anyways. So it's really, really murky. You gotta make the great divide between unassigned patients and your own. So there's a bunch of fair market value surveys out there. MGMA was probably the best known. It's got about 308 sort of systems that have commented on the on-call. Sullivan-Cotter is another one that many of you heard about. They have about 189 hospital systems. But you kind of tell that even the biggest ones, so MGMA, 308, that's a tenth of all acute care hospitals that are out there, right? So they're small samples. And here are some of the other ones. There are a bunch of compensation surveys out there. How much do doctors get paid in certain specialties by zip code, et cetera, trauma, not trauma, academic, not academic. So the problem with using these surveys is it's really, really, really hard to compare apples with apples. So let me give you an example. Here, Sullivan-Cotter for a hospitalist. So they break it up into restricted call, unrestricted call, meaning do you have to take call in-house or out-of-house? And of course, if you take call in-house, you should get paid more. Well, when you start to break it down, the numbers start to get very, very small. So when you start doing subgroup analyses of comparisons of people in your area of the country, people that are similar to you, trauma, not trauma, academic, community, et cetera, I mean, you're kind of getting down to like single-digit numbers, right? And in fact, the on-call providers at your hospital don't care what somebody else down the state is making. They care about what is their buddy at the neighboring hospital making, because that's who he hears about, right? And it's a problem making those comparisons because I'm a for-profit hospital, they are non-profit hospital. It might be I'm a trauma center, they're a non-academic place, et cetera, et cetera. So it gets really, really hard to compare apples with apples. Now, what does the OIG say? It's okay to kind of make these fair market value evaluations based on national market rates, local market rates, frequency of a call, the burden of the call, et cetera, et cetera. I'm going to move on here a little bit. So how do you cause this change in your hospital? So if you're like most hospitals, the stipends are just too high, right? And the hospital's worried about them getting cracked down on. So I borrowed this quote actually from somebody's earlier talk. I think I borrowed it from Brent. I forget, but it's essentially give people a stake in the outcome by making sure they participate in the process, because if they are not involved in the process, they are hardly likely to approve the product. And in a sense, the process is the product. So you got to get buy-in. You got to get the stakeholders to the table. So when you get them to the table, what do you hear? Well, the ED call members, what are their priorities? They care about something that's fair and equitable, okay? So the pediatrician doesn't want to get totally slammed by these high and feel really unfair when these surgical subspecialists are making all this money. They want to get paid for carrying the pager, so just before being available, I want something. They want something, a productivity base. So if I work really hard, I want to get compensated more. And I understand if I don't get called, I want something, but I understand that I'm not going to get paid all that much. And probably most of all, it's about their lifestyle, because it's not about the money. When you really kind of get them at the table, no amount of money, and we've experienced this in Denver, there's no amount of money, well, we didn't offer like 7 figures, but there's, money isn't the most important thing. So you got to understand the concept of pager burden. And the pager burden, again, I kind of grew up with pagers. I mean, I was trying to get a picture of my dad's old pager from 40 years ago, but there wasn't one, so I drew one in. It's the one on the left. This is what pagers used to look like. There just used to be a button that flashed or it went off and you didn't know who called, so you figured it was the hospital, so you called the hospital back, to now that they've updated the pagers, but they haven't changed a whole lot. But it's something the emergency medicine docs kind of have to understand a little better, because it is a burden to carry the pager. I mean, my wife's an endocrinologist. She was in solo practice, on call 365 days a year. She didn't get a call a whole lot, but when it did, it really stunk, especially when it was in the middle of the morning. What would the hospital like to have? They'd like, to pay, to kind of link availability with some sort of quality measure. So it's not like I'm just paying you for nothing. Especially, they really hate it if you pay an on-call specialist who will just take the phone call and transfer to another hospital. They really don't like that, because you're shipping business elsewhere. And they're really more worried about the long-term viability of the hospital. Okay, so some of the solutions here in the last few minutes. There's this huge megatrend between outpatient medicine docs and inpatient medicine docs. We're all familiar with the hospitalists. It's for the past 2 decades, they're probably the fastest growing specialty, and we work hand in hand with the hospitalists. But there's intensivists, there's laborists, there's surgicalists, there's traumatologists, orthopedists, and our group, a Denver group, we just hired a whole group of neurohospitalists where that's all they do. They just see hospital consults. So alternative strategies. For hospitals, employment is a real big thing because it's kind of the safe harbor of exceptions, so you don't violate Stark, you don't violate the anti-kickback statute, and they have some kind of control. And it's just kind of written in your contract that you're going to work a certain number of days, and calls a part of it. And it kind of works. It kind of works for people. Mid-level providers is another big thing. So we're all kind of used to mid-levels, but now they are taking first call. So like at our hospital, if you call the urologist, you get the mid-level first. If you call the spine service, you get the mid-level first. And it's actually not bad. It's really not bad. It's kind of like the days when I was attending at an academic emergency department, you call and you get the resident or you get the fellow, except PAs are a lot nicer and usually more helpful. So OBS units, which Jay talked about yesterday, are going to become really, really big because it lowers the call burden on the specialists. And then regional sharing coverage, which is just not realistic for most people because, the hospital across the street is a competitor, or you're a critical access hospital and there's no other hospital around. So it's a problem. And telemedicine is going to get bigger and bigger and bigger because now you can do regional coverage because, the hospital will be 50 miles away and you can still offer some sort of call coverage. So some innovative benefits. Deferred compensation is a big one to be explored. People talk about it a lot, but in reality, only about 5% of all on-call specialists are compensated this way because for the tax benefits. And they talk about the rest of these things on the list, but in reality, hospitals don't want to practice medicine. They don't want to violate any rules. And so there's less and less of these uncompensated ways, compensation methods. So you're going to go back home and you're going to say, okay, what can I get from this talk? And one of the main things you can get from this talk, especially if you're on med staff or med exec committees, is to make sure your bylaws, make sure your hospital is kind of paying people in a compliant manner. So the compliance issues that are really common. So there's no call schedule, right? So there's kind of, I call the GI doctor when I need them. Well, that doesn't work for the OIG. They have to be on a call schedule, on a calendar, and when they're called, they gotta be there. You gotta document your on-call services, and that's something that we're struggling with, just because in the end, it's gonna go towards the a la carte method. You gotta be able to document for the work you do. Double payment's a no-no, okay? So that's a really quick way to get an OIG visit. Medical directorships, so a lot of your medical directors, you can't be paid for being on call and being a medical director, at least not at the same time. So what should you do now? Get the data. You gotta get the data, because if you're not gonna need it now, you will need the data. So this is your jump start. Work with the hospital on existing policies. Make sure you're in compliance. See at your hospital, what is the current temperature of the on-call specialist in the hospital? Are they happy? Are they not happy? Because it's gonna come to a head. And when it comes to a head, and you're like that trapeze artist, people are gonna start falling, And it's hard to keep your balance on the tightrope spinning plates when the next person to you just fell. Any questions? Thank you for your time.